Here we go. So here we have a 56-year-old woman presenting with progressive dysphagia. Now, she's had a previous history of gastroesophageal reflux disease, so already I'm thinking of how that might factor into what's going on here. On the contrast swallow images, I'm noticing a narrowing of the lumen in the mid-aspect of the esophagus. What's quite striking are these flask-shaped outpouchings seen at a right angle to the esophageal lumen, measuring about 3 to 4 millimeters, and they communicate with the lumen through narrow necks. This pattern of outpouchings makes me immediately suspect a relatively uncommon condition. Another important detail is that there's no visible mucosal irregularity elsewhere, which rules out other potential conditions like a primary tumor. As the contrast flows down, there's some dilatation of the lower part of the esophagus, which looks featureless. I'm seeing tertiary peristalsis, and there's a delay in the opening of the gastroesophageal junction, which could explain the symptoms of food stalling at that point. Then there's a thin line of contrast along the anterior wall of the trachea. That's a key sign, suggesting a small amount of aspiration into the respiratory tree. Again, this correlates with the patient's history of dysphagia and potential aspiration. At this point, the diagnosis I'm leaning toward is oesophageal intramural pseudodiverticulosis. It's a rare condition, typically benign, but it can lead to significant morbidity because of its association with strictures. These outpouchings represent dilated excretory ducts of the submucosal glands of the esophagus. And this woman's past history of reflux disease really supports the chronic inflammatory changes I'm seeing here. It also explains the scarring and stricturing in the mid-esophagus. Of course, it's always essential to consider the differentials. This could very well be a peptic stricture, given the chronic reflux disease, but the distinctive appearance of these outpouchings makes pseudodiverticulosis more likely. Also, aspiration complicates things, so we need to be vigilant about monitoring for further respiratory compromise. Management-wise, I'd definitely involve the gastroenterology team early. Endoscopy is essential, not only to visually assess the extent of the esophageal damage, but also to take biopsies and rule out candida infection. It's something that's often associated with this condition. If confirmed, treating the infection is crucial. Depending on the severity of the stricture, endoscopic dilatation of the esophagus might be necessary to relieve the obstruction and improve the patient's quality of life. This case serves as a reminder of how these relatively rare conditions can manifest subtly at first, but have significant complications if not recognized early. We also have to watch for progressive stricturing, and as seen here, the risk of aspiration pneumonia. Thanks for joining me on this case. Don't forget to subscribe to Radiology Made Easy for more insights like this one. Let's keep exploring and breaking down cases together.